Hello everyone. I'm Dr. O from the Taiwan Medical Mission. Today I will share Taiwan's experience on infection control in hemodialysis and how these practices can be adapted to the clinical setting here in Somaliland. Hemodialysis patients have a high risk of infection, so having clear and practical protocols is very important. In the next part, I will explain the basic principles and show how protocols should be designed based on local conditions. Let's move to the first concept. For infection control protocols, one important idea is this: they must fit the local environment and the local resources. Even if we follow international guidelines like CDC or KDIGO, we still need to adjust the protocol based on staff availability, supplies, and the overall socio-economic situation of the hospital. So before we talk about catheter care or antiseptics, I want to emphasize that good infection control is not just copying a guideline. It is adapting it to what is realistic and sustainable in our setting. Next, I'll show how this idea affects invasive procedures, especially temporary HD catheters. So here is the outline for today's session. We will focus on three main parts. First, antiseptics in invasive procedures, especially temporary hemodialysis catheter insertion. Second, prevention of hospital-associated infections, including catheter-related bloodstream infections. And third, environmental cleaning and dialysis water monitoring, which is a key part of infection control in any HD unit. These three areas together cover the essential points for maintaining safety in hemodialysis care. Next, let's start with the first topic: antiseptics used during invasive procedures. Now we start with the first topic. When placing a temporary HD catheter, the key step is proper skin disinfection. We may use reusable or disposable drapes, depending on what we have, but the principle is the same. The skin must be cleaned well to reduce infection. Next, I'll show which antiseptics we use. This slide shows that good aseptic technique really works. With a proper aseptic bundle, catheter infections dropped from 7.4 to 2.1 per 1,000 catheter days. Training also helped reduce infections by about 28%. So the message is simple: full sterile barrier plus full drape plus hand hygiene equals lower CLABSI. Next, we'll look at the common pathogens. These are the most common pathogens in dialysis catheter infections. The majority are coagulase-negative staphylococci, about 65%. We also see S. epidermitis, S. aureus, enterococcus, and some E. coli. And an important point: MRSA is still a major concern, especially in hospitals with limited resources. Next, we will compare reusable and disposable drapes. This is the basic setup for inserting a temporary hemodialysis catheter. Everything on this table must be sterile. We prepare the drape, catheter kit, syringes, dressing, and ultrasound gel. The key point is simple: set up all sterile items before starting, so the procedure can be done smoothly without breaking aseptic technique. Next, I'll show the steps of the procedure. Here is a simple comparison between reusable and disposable drapes. Reusable drapes are cheaper, softer, and good for resource-limited settings, but the barrier may fail if they are old or not processed well. Disposable drapes give a more consistent and high barrier, but they cost more and depend on supply availability. In short, reusable equals cheaper but needs good sterilization. Disposable equals better protection but higher cost. Next, let's look at the techniques for catheter insertion. There are two main techniques for inserting a dialysis catheter. On the left is the landmark or blind technique. This is used when ultrasound is not available. On the right is the ultrasound-guided technique, which is safer and recommended whenever possible. In short, use ultrasound if you have it. Use landmark only when you don't. Next, we'll go through the steps of the procedure. Step 1 is prelocalization. Before starting, we use ultrasound to find the vein, check its size, and confirm the best entry point. This makes the procedure safer and reduces failed attempts. Next, we'll move on to skin preparation and draping. Step 2 is aseptic preparation and draping. Here, we clean the skin with antiseptic and then use a full sterile drape. The goal is to create a completely clean working area so the catheter can be inserted without contamination. A full drape is part of the CDC maximal sterile barrier. Next, we'll move to the insertion step. Step 3 is the semi-blind insertion. After we finish the draping, we insert the needle using the anatomical landmarks we confirmed earlier. Even though we use the landmarks, we still keep the ultrasound nearby to recheck if needed. The key point is slow insertion, correct angle, and confirm blood return before advancing. Next, we'll continue with the comparison of different insertion methods. Here is a simple comparison of the 3 catheter insertion methods. Real-time ultrasound guidance is the safest because you can see both the vessel and the needle, but it needs good sterile technique and a skilled operator. Ultrasound prelocalization is a good balance. You map the vein first, then do the procedure normally. It improves accuracy and keeps the setup simple. The landmark method can be used anywhere, but it has the lowest success rate and more complications. This is why many centers prefer prelocalization when full real-time ultrasound is not available. For the second part of today's session, we'll focus on 3 key areas in infection control. First, antiseptics used in invasive procedures, especially for temporary dialysis catheter insertion. Second, prevention of hospital-associated infections, including how to reduce catheter-related bloodstream infections. And finally, we'll talk about environmental cleaning and dialysis water monitoring, which is essential for keeping the HD unit safe. Many pathogens can survive in the environment for a long time. For example, MRSA can stay on surfaces for up to 38 weeks, and VRE can survive for as long as 6 months. This is why regular cleaning and good infection control practices are essential in dialysis units. Infections usually spread in 3 main ways: contact, droplets, and airborne transmission. A contaminated source can pass the pathogen to a vulnerable person through touch, through respiratory droplets, or through the air, depending on the organism. Understanding these routes helps us choose the right prevention measures. Contact transmission is the most common route in dialysis units. Infection can move from one patient to another mainly through the hands of healthcare workers. If hands are not cleaned properly after touching patient A, the bacteria can easily be carried to patient B. So hand hygiene is the most important step in preventing contact transmission. For infection control, healthcare worker practices are extremely important. We start with standard precautions. Hand rub must be available at the ward entrance and bedside. Gloves should be available for all staff. And gloves must not be reused between patients. We also need regular audits. Hand hygiene is checked every month, and aseptic technique is reviewed each season. These steps help keep both staff and patients safe. Now we move to the final part of the session, which focuses on 2 important areas in dialysis infection control. The first is environmental cleaning, because many pathogens can survive on surfaces for weeks or even months. The second is dialysis water monitoring, which is essential for preventing outbreaks and keeping patients safe. These 2 parts form the foundation of a clean and safe HD unit. Environmental cleaning is very important in dialysis units, because different situations require different bleach concentrations. For MDROs or C. difficile, we need to clean with 1000 ppm bleach. If it's a small blood spill, less than 10 milliliters, we use 500 ppm bleach. If it's a large spill, more than 10 milliliters, we need 5000 ppm bleach to make sure it is fully disinfected. And after applying bleach, we always finish with detergent or soap plus clean water. In hemodialysis units, different items require different levels of disinfection. For anything with visible blood, we need intermediate level disinfection because the risk is high. Items like dialyzer port caps and the interior pathways of the dialysis machine also require intermediate level disinfection. For the water treatment system, we usually use low level, but if there is biofilm, then we need intermediate level. Tools such as scissors, hemostats, clamps, and stethoscopes can be cleaned with low level, but if they are visibly contaminated with blood, we need intermediate level. Finally, environmental surfaces and the exterior of the dialysis machine are cleaned with low-level disinfection as part of routine practice. The key message is, visible blood equals intermediate level, routine cleaning equals low level. For dialysis water quality, we follow microbial count standards. Both TSN98 and TSN102 set the same limit. Dialysis water and standard dialysis fluid should be under 200 CFU/ml. For ultrapure dialysis fluid and substitution fluid, the expectation is zero growth, meaning no bacteria detected. And if the microbial level is over 50 CFU/ml, that reaches the action level, which means we must check the system and take corrective action. Now about the culture method. Earlier guidelines used higher temperature, 35 degrees Celsius, for 48 hours, but the updated TSN102 changed to lower temperature, 17 to 23 degrees Celsius, for 7 days, because this method is more sensitive and can detect more slow-growing bacteria. Now let's look at endotoxin standards. For dialysis water, both TSN98 and TSN102 require endotoxin to be below 2 EU/ml. For standard dialysis fluid, ultrapure dialysis fluid, and substitution fluid, the requirement is nil, meaning no detectable endotoxin. Even the action level is also set at nil, so any detectable endotoxin means we need to check the water treatment system immediately. Here I want to show one recent study from the Indian Journal of Medical Microbiology, published in late 2024. This study focused on dialysis units in resource-limited hospitals, very similar to many settings we see in Somaliland. They evaluated the microbiological quality of dialysis water and dialysate and found that improving water treatment and infection control practices can significantly reduce contamination. So this supports the same message we are discussing today. Good water quality plus strict asepsis equals safer dialysis care. This study was a cross-sectional design. It was done in a 250-bed government hospital with a hemodialysis unit that had 40 machines. Every month, they collected dialysis water and dialysate samples and tested them for microbial contamination and endotoxin levels, following AAMI guidelines. For the results, out of 740 samples, 19.6% were unacceptable and 80.4% were acceptable. But even among the acceptable samples, 10.5% reached the action level, meaning the water quality was borderline and needed intervention. For the conclusions, this study clearly shows that regular monitoring of water quality in dialysis units is essential. And to keep patients safe, we need a comprehensive approach, using multiple testing methods to detect contamination early and make timely improvements. In addition to water quality and aseptic technique, there are a few more key points for infection control in the dialysis unit. Vaccination for healthcare workers, especially hepatitis B. Cohort or isolate MDRO patients. Keep them separate to prevent spread. Prevent droplet infections, masks, and good ventilation. Prevent blood-borne diseases, HBV, HCV, HIV. No sharing of supplies, safe needle handling. That's it, simple but very important. For future improvement, we can focus on two things: use reusable gowns and drapes, and make sure they are sterilized regularly with the autoclave. Start monitoring bacteria from dialysis sets, meaning we should establish basic culture testing in the hospital. Infection control is essential for maintaining safe and effective medical care. Using proper antiseptics during invasive procedures, keeping good hygiene, and regularly monitoring for potential contamination are all critical steps to prevent infections. In resource-limited settings, it is often challenging to balance safety with cost, but continued attention to infection control remains crucial. Thank you everyone for your attention. I hope today's session helps improve our infection control practice in the HD unit.